Good evening, everyone. My name is Colin Davidson, and I'm the president of the College of Optometrists and also your host for this evening. So I'd like to wish you a very warm welcome to today's webinar, where we will hope to be able to shine a light on post-pandemic optometry. Although it seems we haven't really entered the post-pandemic phase when more restrictive lockdown measures are being taken across all the UK and a second wave of COVID-19 has been mentioned, we can all agree the pandemic has brought unprecedented challenges for all of us, both personally and professionally. It's also changing optometry and eye health care for the foreseeable future, if not forever. While the immediate implications for practice are not known, the long-term impact of the pandemic on eye health and care is still very uncertain. During this pandemic, we had to embrace the use of technology to continue to provide eye care services remotely and safely, develop new clinical practice, and adapt to changing patient needs. We know that these changes we thought would be temporary will all have a profound impact on UK optometrists in the near future, and we'll have to ensure that our profession is fully prepared to address the challenges and maximise the opportunities that lie ahead. This includes addressing workforce challenges, developing new ways of working, and harnessing new technologies and interventions to improve patient outcomes in every workplace and setting. So tonight we ask our panellists for their perspective on how optometry will change post-pandemic, and we'll put your questions to the panel. So if I could ask all our guests to switch on their webcams and join me on screen. And tonight we'll be joined by Lisa Gerson, who's Chair of Optometry Wales, Lesley Longstone, Chief Executive and Registrar of the GOC, Julie Mosgrove, who's Vice Chair of Optometry Scotland, William Stockdale, Chair of Optometry Northern Ireland, and Richard Whittington, the Chief Executive of Longstone. So welcome everyone, and thank you for joining us this evening. So just before we start, I think it's good to run through a bit of housekeeping. So throughout the session, you can submit your questions via the question drop-down box, which you'll find on your control panel. If you do this, go to the right-hand side of your screen if you're using a PC or a laptop. If you're on a mobile, the question icon could either be at the bottom or at the top, depending on what you're using. So again, it's shown on the slide here. You can also use this function if you get any technical issues. So just let us know and we'll see if we can sort that out for you. Or you can also email events@college-optometrist.org for any technical support. And I'm sure, as we're all used to at the minute with everyone logging on and doing remote events, make sure that you've got all windows and apps closed and that you or anyone else is using your internet aren't downloading or streaming anything which might affect your bandwidth during the webinar. So let's press on with what promises to be both a fascinating and thought-provoking event. So I'm going to ask all of our guests to introduce themselves, and we'll do that in alphabetical order. So I'm going to start with Lisa from Optometry Wales. So Lisa, if you'd like to introduce yourself, please.
Thank you, Colin. Good evening to everyone, and grateful to the college for inviting me here this evening to shining a light on the post-pandemic optometry. My name is Lisa Gerson, I'm the Chair of Optometry Wales. Optometry Wales is the professional umbrella organisation for all optometrists, dispensing opticians and optometric practices across Wales. We also ensure that we represent the views of the UK optical bodies when we lobby Welsh Government in order to represent the best interests of the profession in Wales. We negotiate local and national commission services. During the pandemic, we worked closely with Welsh Government to deliver a 4-month package of financial support to practices, to ensure that practices had access to unlimited PPE at no charge, and to develop policies to help divert patients from secondary care into primary care. The most outstanding example of this is that within 24 hours, We equipped all IP optometrists in One Health Board with prescription pads and diverted 80% of eye casualty patients into primary care for diagnosis, management and treatment. Although the financial support has stopped due to the analysis of our data collection highlighting the need to return to full claim submissions, we continue to supply free PPE to all practices as we work through an amber phase to our routine appointments, and domiciliary services are now in full flow again. Thank you.
Great, thanks, Lisa. So we'll pass on to Lesley. Hi, Lesley.
Hi, Colin. I'm Lesley Longstone, Chief Executive and Registrar at the General Optical Council. And again, thank you very much for the opportunity to be here today. It's really helpful. The GOC's kind of core purpose is public safety, and that has been our role in the pandemic as it is at all times. Ordinarily, we ensure public safety by doing a number of different things. One, by setting entry qualifications for the profession. Secondly, by setting standards of practice. And thirdly, by investigating complaints when there are questions about whether those standards are being adhered to. And I think early on, we recognised that the pandemic meant that things were not going to be exactly as they had been previously, and there was a kind of a risk that, far from ensuring the public safety, our standards and our rules would actually undermine public safety if practitioners were prevented from doing the right thing because of fear of getting the wrong side of the regulator. So quite early on, right at the very beginning of March, we issued a statement, a joint statement with a number of the other healthcare regulators, which essentially said that we recognise that there are going to be a lot of unknowns over the next few weeks, months, as it turns out, probably year. And although we don't know what all the detailed questions are going to be, there's one thing we're really confident of, and that's that we're going to have to trust in professional judgment and trust in your professional judgment. And so the message we tried to convey, and we've done that throughout the pandemic, is if you are trying to do the right thing by the public, given all of the uncertainties, if you're following the advice and guidance that's out there, but you're acting in good faith, then we will support you as a regulator, even if things go wrong. The corollary, of course, is that if you demonstrate blatant disregard for public safety and the advice that's out there, then we will just treat complaints in the same way that we would always include in consideration of FTP cases. So that was kind of the general overall approach that we took, and then we moved on to set out a number of statements, and these statements fell into three broad categories, I would say. One category was just updates around relevant guidance that was being issued by government, by public health authorities, by the colleges, in fact. The second series of statements related to clarifications around our standards, or in some cases easements, where actually we decided that what we would normally ask of registrants just wasn't reasonable, and therefore we had to make some changes. And then the third category were GSC process changes, where we, because of remote working, had to do things differently ourselves as well. And all the time we were striking a balance between get this out quickly, because there were questions coming at us the whole time, as you can imagine, but also making sure that it was. And we had a small kind of working group. We worked very closely with the college and ABDO and AOP, FODO, etc., and turned around a series of statements in pretty quick time, usually just a few days, if that, to turn statements around. And normally I think we got it, pretty well right. We had some really positive feedback. We've also had one example where we didn't get it right and we caused a lot of confusion and upset, for which we've apologised. But generally speaking, I think the approach of trusting in the professionalism of our registrants has been at the heart of all of the statements that we've issued. The outcome has been relatively few complaints from members of the public about lack of care or poor care during the pandemic, and contrast that with a number of the other healthcare regulators, which is really, really positive. It means that generally practices were able to meet care needs throughout, and that's really positive. We've had some FTP, but not very many. They tended to be practice on practice complaints, some of which have progressed to formal fitness to practice hearings, some of which haven't, either because they weren't substantiated or they were relatively minor issues. Registration continued as normal. We are almost at the end of student registration. Numbers have held up despite the issues around A-levels this year. We've made a lot of temporary changes to our education requirements in super quick time, and I know that it's never quick enough, but what would normally have taken months has taken a few weeks, and all of those proposals have now been authorised. And of course our fitness practice hearings have continued, but they've continued remotely, like many other things. Looking to the future, first of all, we're not through this yet. And you know, just the last week or two has shown just how far we've got to go. We are actually still looking at some emergency legislation. We were at the top of the Department of Health and Social Care's priority list, as you can understand, but we are there now, so we have been considered for some additional emergency legislation. We're just about to enter a 12-week consultation period on all of the statements that we issued, because they were done really, really quickly. And it was great to get the feedback that we did, but we know that we would benefit from public consultation. So you will get a chance to tell us, have they worked? Did they have the expected benefits or not? If they should be continued, then we've tried to link them to the college's traffic light system and suggest that they should be easements that apply at different phases. So we're asking for your feedback on that as well. And also we'll be asking the question about whether some of these changes should be made permanent or not. So that will be really good to hear from you. I think the other, and I'm nearly finished, the other big issue for us going forwards is actually how we respond to the way the sector responds to COVID. And that's about, yes, the shift, more technology, etc., but in particular, the role that the sector will play in addressing backlogs in secondary care and what that means for the way that we set standards and ensure public safety. Fortunately, we were quite a way down this track with the Education Strategic Review, which anticipates greater clinical content, more integrated provision, and a much higher level of kind of quality assurance alongside that. So that's really, really important. We've just closed the consultation on the ZT changes, so they will come very shortly, and we will be making sure that changes to ESR and the CPD scheme mirror each other. And then finally, only this week, we kicked off with the latest of the expert advisory groups to look at independent prescribing and contact lens opticians expert advisory group as well. So again, work that was already in hand, but what the pandemic has done is it's just accelerated progress. It's accelerated progress in the sector in the direction of greater clinical content. I'm sure we'll talk more about that today. And I think that, you know, this acceleration of change because of the pandemic, I'm sure we'll hear that lots in lots of different sectors and lots of different professions, but I shall leave there. And I think my job then is to hand you over to Julie Mosgrove, who is Vice Chair of Optometry Scotland.
Hi everyone, and thank you very much for inviting me along today. My name is Julie Mosgrove and I'm the Vice Chair of Optometry Scotland, and I'm also an IP optometrist based in Grampian. So Optometry Scotland is a non-profit organisation and we represent our members in Scotland. It's obviously been a busy time for everyone during the pandemic. We've had ongoing meetings with the Scottish Government, building a very good relationship both with them and also working alongside kind of secondary care during lockdown and organising treatment within the kind of primary care setting as well, and also going forward into the future. So it's been a very busy time, and there's been a lot of good that's come of everything, and look forward to the future, which we'll probably discuss a wee bit more tonight as well. So I'm going to pass over to William Stockdale, the Chair of Optometry in Northern Ireland. Thank you.
Hello, hi, thank you. I'm William Stockdale, Chair of Optometry Northern Ireland. We represent the views of all optometrists, contact lens opticians, dispensing opticians in Northern Ireland. We work with the Health and Social Care Board to negotiate fees, develop new schemes, and through our sister organisation, the NIOS, we provide CET and CPD. The biggest challenge, obviously, in the last 6 months has been the cliff edge that we faced back in March. Everything stopped, and suddenly you were faced with decisions you'd never had to make before. The businesses at that stage weren't viable, practices weren't viable, and very, very quickly we had to work to get something in place to ensure that the practices survived. We're very lucky in Northern Ireland. We have one point of contact at the Department of Health and one point of contact at the Health and Social Care Board. They established a three-way communication very, very quickly, and we were able to put in place a financial support scheme, which basically underwrote the practices in Northern Ireland for the coming months. On its own, the financial support scheme wouldn't have made a practice survive or allowed a practice to survive, but that combined with the job retention scheme, with other government support, with the banks starting to change their attitude and starting to actually lend money, which at the start they weren't prepared to do, meant that practices became viable, which was fantastic. We were then able to establish the proper methods of care for people, so that throughout the pandemic, every practice in Northern Ireland stayed open and continued to provide urgent and essential care. We've been very much supported in the last 6 months by all of the professional organisations, Photo, Abdo, AOP, the College, the GOC, and Optometry Wales, Optometry Scotland have all been a huge support to Northern Ireland, and I'd like to thank them for that. They have been available literally 7 days a week, and we've had some strange conversations at 2 and 3 o'clock in the morning about particular issues that needed to be sorted. Again, in Northern Ireland, we are lucky. We have one head of ophthalmic services, an optometrist by profession, Raymond Curran, and he has been a huge support to the profession over the last 6 months. Raymond has worked tirelessly to support us and to help us, and we're very, very grateful for that support. And in return, the profession has been magnificent. The profession has responded and delivered care throughout the last 6 months. We've built huge levels of trust between ourselves, ophthalmology, the board, and the Department of Health, and we're now in a fantastic position to move forward. That's really it from Northern Ireland, and I'd like to hand over to Richard Whittington, Chief Executive of Longstone.
Thank you, William, and thank you to Colin and the College for inviting me to this session. My name is Richard Whittington. I'm the Chief Executive of Longstone, and we work in England supporting the primary eye care companies and LOCs across the whole range of their work. So commissioning support and commissioning advice we give, but we also support the LOCs in particular around development, all the range of their work, so things like CET. We're working a lot in continuity and succession planning, and really looking to see how we can help them to promote and drive the sector forward in their conversations with commissioners at system level. We also work in conjunction with our parent organisations, the AOP, Abdo and Photo, particularly through the OFNC piece in terms of negotiating the main contract, which I'm sure we'll talk about a bit later. I think the pandemic threw up just a huge number of challenges for us in England. Unlike our colleagues in the rest of the UK, our commissioning structure is quite complex with the CCGs, particularly for extended services. So as LOCSU, what we had to do in the first instance was support the LOCs to continue with their work, which we did through the formation of regional forums, which were run throughout the pandemic. And this brought LOCs together in geographic areas that mirrored the NHS England areas, and allowed them to begin to talk across the system and to look to see where there are challenges very particular to specific areas, and also where there were challenges nationally. We also recognised that there were about half of the CCGs in England, just a bit over, who were commissioning a MEX type service. And there was going to be a need for some kind of urgent service to be delivered in primary care to help mitigate the immediate COVID response. And that led to the formation of the queue service. That I have no doubt will come up in questions, so I'm not going to talk too much about that now, but that was very much driven by the need to have a service that could be taken off the shelf in the areas that didn't specifically commission a minor eye condition service at that particular point. Coupled with that, we recognised that PPE was going to become a really big issue. We were discussing through FNC work, we were just discussing specifically around how PPE was going to be provided to practices. But in the intervening gap, LOXU, in conjunction with Primary Eye Care Services, one of the primary eye care companies, set up the PPE shop, which allowed the supply of PPE at cost to all those in England initially who wanted it, but also that was spread out to other areas in the UK. I've mentioned OFNC, and I've worked with OFNC. I'm an observer to OFNC officially, but I'd like to think I'm a quite vocal observer. And we've been working to put in place the practice support in England. That has been a challenge. People would have noted that there's been a statement from OFNC today about where we are currently. But I think working across all of the representative bodies in England has enabled us to be able to get at least as far as we have got. Looking to the future, I think from a LOXU perspective, we need to continue to support and develop the LOCs to be able to be that voice of the profession locally. They are the local experts. They are the people that will fundamentally drive the system changes that I think we're going to see. Pathways, we'll be building on the pathways we already have published, but there will be new ones to follow, and that will very much dovetail in with the work of the Outpatient Transformation Project, which is a national project looking at outpatient transformation as the term would suggest, but is also very fundamental in trying to understand what can be delivered in primary care, and I use the word primary care very deliberately in this. What can be delivered in community and what can be delivered in hospital. And LOXU's aim is what it always has been, which is to champion optical practice as the right place for first contact care, to be the place of choice for patients when they first have an issue with their eyes, and to help drive the shift of activity away from hospitals and into primary care, not only because it's probably the safest way to deliver the COVID response, but also because in the long term and to support the recovery, we are going to need to be able to help with the capacity challenge, which is going to be felt right across the system. So with that, I will now hand back to Colin for the rest of the evening.
Thanks ever so much, Richard, and thanks everyone for your introduction. So I think everyone listening in will agree we've got a great panel this evening with a wealth of expertise that hopefully we can all tap into. So I'm going to ask all our guests if they could switch their webcams on and join me on screen. And our first question, which I think we may have answered slightly in some of the opening introductions that you've made, but the first question, which is I think rather sneakily several questions in one, was around the future of the profession in a sort of short-term, long-term, and maybe opportunities and challenges that lie ahead. So I'm going to look to my panel and see who would like to kick off with that. Lesley, is that something you would feel comfy with chatting to us with your perspectives on this?
I'm very happy to kick off. I think in the short term, it's obviously going to be tough for lots of organisations and for individuals. I think we're really conscious of the impact on locums in the very short term. Businesses have found it really difficult the last few months, and no doubt it's going to carry on being difficult over the next few months. I think, however, that my medium to long term kind of view is that the profession's still got a very, very strong future. And that's, if you just boil it down to its absolute basic, what we have is an ageing population with generating demand for eye care services, and a profession that has got tons and tons of capacity to be able to address problems elsewhere in the system. And Richard and others have talked about how we need to drive care out of secondary and into primary care. And I think that creates a really strong future. But I do think that it means that it is going to be a more clinical kind of approach in the future compared to where we have been hitherto. But interested in whether other people share that view.
Great, thanks, Lesley. It's interesting. I've been chatting to colleagues throughout the pandemic, and they feel they've had a more clinical role to play in the patients that you've been seeing. So it's interesting to hear what you say from a clinical perspective going forward. I wonder if any of our other panelists have got any thoughts. I might just, the way everyone's on my screen, I might come to Julie next and just say, what are your thoughts from a north of the border perspective?
Yeah, I think north of the border, I mean, there's been a lot of learnings that we've had, obviously, during lockdowns. I think going forward, when we were in lockdown, we had put in remote consultations that obviously came in. The fees changed at the time for IP optometrists, claiming remote consultations as well. So there was more emphasis on the IP qualification as well. I think we're also looking at different health boards at the moment are putting together different ideas for how we can see secondary care patients in a primary care setting. So certainly I think there is going to be a bit more of a shift towards seeing these patients. It makes sense to see them in practice. As Lesley said, we've got the capacity, we've got the qualifications and the understanding as well for a lot of these kind of clinical conditions, and it saves the patient travelling. We can be seeing them in remote and rural locations rather than travelling to hospitals, which might be miles and miles away, especially in some areas of Scotland. So no, definitely, I think it will be kind of shifting more that way in the future. I think in the short term as well, like Lesley was saying, we are obviously quite busy at the moment. There's a lot of still that kind of pent up demand kind of still there, but I think it will quieten down, and definitely we'll have the capacity to see these patients in our practice.
Okay, great. Thanks, Julie. And Lisa, from a Welsh perspective, what are your thoughts on the long and short term and the challenges and opportunities?
Yeah, thank you, Colin. As has already been said this evening, I think the pandemic has certainly accelerated progress. And in Wales, we've seen there have been enormous opportunities that we've been able to take advantage of. We now have weekly negotiations with Welsh Government over the contract for the profession in Wales. This reform, it will be much more focused on the clinical delivery of service, on reducing the need for the reliance on a cross-subsidy and the diversion of referrals into secondary care. In the short term, we need to understand what our workforce looks like, and now that the fires of COVID-19 have washed through the profession, although revisiting, as we know only too well, many of the domiciliary companies are in a fragile state. But now with the data, it's showing that the patients needed us through the pandemic, whether it's from fixing a pair of broken glasses or the treatment of wet AMD. And across the piece, we are needed once more. And what we're also doing in Wales is we're close to signing off an agreement that remote consultations for some of our EHU services can be remunerated. And this will be a huge step forward for the profession. Welsh Government are also paying in full for the installation of the Attend Anywhere service. And this is the same remote consultation platforms that our colleagues in general practice, the GPs, use. So again, we're sort of seeing how optometry within Wales reflects against other primary care providers.
Okay, great. Thank you for that, Lisa. And it's great to have your perspectives there. And William, from your point of view in Northern Ireland?
Hi, Colin. Much the same. I mean, the next probably 5 or 6 months, the short term is all about survival, getting through the winter. 3 weeks' time, we have the end of furlough, which will be a massive change in the dynamic of practices. We're heading into local lockdowns, possibly circuit breakers, all these things that are being talked about. So really, for me, the next 6 months is survival. Let's make it through to April and see where we are then. Practice as well. The demand is there. All the things that were said are 100% correct. But the short term is just seeing how we go over the next few months. Once we get through that, the outlook, I think, is very, very, very good. As Lesley said, we have an aging population. There is demand for eye care. We have proven in the last 6 months what we can actually do. We have massively changed the opinion of ophthalmology. So we now can start to see schemes come on possibly faster with more confidence. And we start to see that move from secondary care to primary care. So I think once we get through the next few months, the outlook for optometry is excellent.
Great, thanks, William. I think it's been great to see how optometry has stepped up and dealt with the challenges that have come along, and certainly from a college perspective, in the discussions we've had with the Royal College of Ophthalmologists, they've been really recognising the good work that optometrists have done in the community. So it has been fantastic. And finally, Richard, if I could come to you just for your thoughts on the long and short term and the challenges and opportunities.
Thanks, Colin. Yeah, I mean, I echo the comments that my colleagues have made. Really, I think in the short term, William's right. It's about survival, but it's also about recovery. I think the difference between the wave that we're going to see now, or we are seeing now, and the one that's gone previously is we had a big lockdown. I'm not saying we actually did have a lockdown. We had a big lockdown last time around, which I don't think we'll get this time around. So I think there'll be certainly the intent to keep services running, keep them open, and that's both in primary care and hospital care. So I think in the short term, those aims are I would echo those. Long term, I agree. I think there's a huge opportunity. I think there's a huge opportunity with the outpatient transformation project as that starts to come on stream and people become aware of that. And that's going to provide the opportunity to deliver way more services in primary care, probably in a slightly different way to the way we've done it before. I think as we start to move towards system-based commissioning, that may well change the way in which services are commissioned, which I suppose leads me to the challenges. I kind of look in envy at the other areas when they're talking about, yes, we talk to one person and we have a good relationship. In England, when we're talking about these types of services, they are still CCG commissioned, which at the moment means we're dealing with 135 commissioning organisations. Now in April, I think we'll see a big merge. We'll probably see a merger down to, I don't know, maybe 70 odd as CCG start to merge onto ICS platforms. But even then, you're still looking at 70. So that is a complication. So that's challenge number one. Now I think in answering that challenge, what we need to do is speak with one voice. We need to be consistent in what we're saying all of the time, which is something we're trying to do in Loxo. It's something we're trying to do with the primary eye care companies. So I think the best way to maximise the opportunity is not to have kind of facsimile services that all look identical, but to have services that are broadly the same certainly across a system, but then across a country, because by doing that, we can start to really move the services around. Patients can transition between services in a much more seamless way. Be supported by IT, which is another challenge. So I think the opportunities are there, but we've got to grab them, and we've got to be mindful that the commissioning structures around us are on kind of shaky ground at the moment as things change. So opportunities and challenge certainly.
Okay, that's really great to hear, Richard. Thank you. So I think as we've gone through the pandemic, we've had some COVID-related changes that we've had to introduce, and I was just wondering, really, as a panel, what changes do you welcome, and what do you think should we maybe look to make more permanent going forward? So again, I'll look at my panel and see who would like to. Richard, yeah, sure, fire ahead.
I'll go first this time. So I've got two. One's general and one's specific. So I think speed of innovation. And I think actually if we were talking to colleagues across the whole of primary care, secondary care, hospital care, no matter what specialty, what happened in the pandemic is that we were all suddenly given permission to innovate. And actually, once you innovated, you could get things moving. You could get things moving quite quickly. Q's is an example of that. And I hope that that stays. I have a fear that it might not, but I really, really hope that stays, because that innovation process drives change, and it drives change rapidly. Everybody in this call, certainly everybody from England, will be aware of the soup that we march through when we're trying to make changes with localised commissioning. So that's the first one. The more specific one for us is communication. I think what we saw again during the pandemic was the beginnings of the breaking down of the barriers between primary care and hospital care, and primary care and community and hospital. People were beginning to make joint management decisions and joint clinical decisions backed by IT, not universal across the country by any means, but where it was working really well, it really was working well. And I think if we can maintain that communication whilst matching the speed of innovation, the opportunities can really be grasped. And I think we can get out of the soup, but they're the two things for me.
Yeah, I certainly agree with the speed of the way things have moved. It's been incredible, really. You know, since I took over as president in February, the number of meetings I've had and the number of people I've had to get to know quite quickly, but there is a desire to get things done and get things done quickly. And I kind of get what you say about it's almost seize the moment, isn't it, and do it while that desire is there. So I wonder if there's any Julie, did you want to come in next?
Yeah, just to add from what Richard was saying there, I think speed definitely was a big factor that I would want to kind of keep. And I think every conversation that we had, or anybody was having, was around patient-centered care. So that people were making decisions based on what works for the patient, rather than this is what we want to do or this is what we want to do. It was very much, well, what's in the best interest of the patient? And that's something I think we really need to hang on kind of going forward. I think the remote consultations was a big part as well. Just being able to offer remote care. You know, there's so much technology out there now that we're able to take photos of eyes and email them to each other and have a look. You know, patients are able to video call. You know, we're talking, Lisa was saying about the NHS Attend Anywhere. You know, we've been kind of rolling that out as well. And we also had teleophthalmology in some kind of practices across Scotland, and that was something that was amazing, just to be able to set up an iPhone to a slit lamp and actually call an ophthalmologist who was shielding at home and could dial in and see what you were seeing as well. Just being able to offer advice kind of remotely. You know, there's a lot of technology out there. I think that's a glimpse of the future. So that would be my things.
Yeah, I think practices have really been keen to embrace the technology side of things, haven't they? And really drive things forward. Lesley, did you want to comment on your thoughts here?
Yeah, I was just going to say that I mentioned that some of our statements were about easements and clarifications that were asked for in order to support remote working and increase use of technology, etc. And actually, when you look at them, as we are doing now as part of this consultation we're about to run, what you see is that most of them were actually clarifications rather than easements, i.e. people could do this already. But I think because it wasn't commonly done, there were questions about what was possible and what wasn't possible. So I think one of the things that I hope is that we don't slide back, that as a minimum what we've done is demonstrate what can be done. And also the other thing that's been really helpful is that in effect we've had a bit of a natural experiment where we've been able to try some things for a period of time, and it'll be really important to look back and look at the evidence and say, actually, did this create any issues to do with public safety or not? And I suspect the answer is going to be not in most instances on the basis of what we've seen so far.
That's really encouraging as well. Yeah, William?
It's following on again from Lesley. We were given the opportunity to have a go, and practitioners had a go and have done it incredibly well. There's been a realization that a lot of the people that turn up to eye casualty should and could actually be dealt with in primary care. And we've certainly seen a huge shift in Northern Ireland away from eye casualty and directly into primary care. So that's been a tremendous shift, really accelerated over the last few months. And again, that will stay in place. One that seems quite stupid almost is basic clinic management. Whenever we come back, we had to work with needs-led care, and we had to speak to people in advance and possibly phone triage, and that led to actually structuring the appointment book in probably a completely different way, and it's been hugely beneficial. Booking people in for collections for spectacles has been hugely beneficial. It just benefits the flow of patients. At the moment, it benefits safety, but in the long run, I think from a patient care point of view, it does lead to us providing a better service. So there's been a number of things which have been good and will definitely stay in place.
Thanks, William. And Lisa, from your perspective?
Thank you. I would certainly echo everything that's been said by colleagues this evening, you know, the speed of change, the remote working. So I thought perhaps if I highlighted something else that we'd noticed in Wales, and distinctly remember when the government lockdown was announced on the 23rd of March, the amount of communication that we had from professional Wales about what was going to happen to their businesses, their livelihoods, their lifestyles almost. And what we found is that we were able to provision some contingency payments from Welsh Government for the profession in Wales, and that made a huge difference to them. And also, notwithstanding this, there was also a supply, or there is a supply of PPE. And again, for the practices that were remaining open, it was important that they were kept safe and the patients were kept safe. So for us now, it feels that there really is a real culture change in the approach of the health boards, and certainly a much more respectful understanding and relationship between optometry. So that's been a positive for us.
Great, thanks. Yeah, William?
So I just want to come back in, and again, it probably picks up on what Lisa's saying. The flow of communication between all of the organisations. You know, I've only been chair since last June, so really in some ways I didn't have experience pre that, but the level of communication between Photo and the AOP and the college and the GOC has been tremendous. We've been having Zoom meetings, most of the people here, behind the scenes for the last 6 months. You said, I've spoken to people that I had probably never even heard their names prior to this. And again, if we can take that forward and keep those communication lines open, we all learn from each other, and it speeds up the development of all the schemes and all the new ways of working that we want to put in place. So the levels of communication have been superb between everybody.
I'd agree. You know, collaborative working has been amazing, really. I mean, just as we've been chatting, we've had a question come in where somebody has remarked that the Wales, Scotland, Northern Ireland appear to have the systems in place to maybe support their hospital colleagues a little bit better than England, and I think they're asking really what can we do about that in England. I mean, I think Richard, you kind of alluded to it earlier with the multiple CCGs that we have to deal with, and the local kind of commissioning landscape that we have to deal with.
Yeah, I think that's exactly right. I think it's about, there's two bits to that question. There's having the processes and the systems to be able to do the work, and then there's having the structures to be able to commission that work and frankly pay for it correctly. I mean, that is the position that we're in. I think in England, I think we have the systems and structures. I don't think there's a fundamental difference in the way that people can actually work across the different areas of the UK. Where there is a fundamental difference is the commissioning structure itself. So when we're talking about GOS, when we're talking about these services, we're talking about two different types of commissioning. We've got NHS England commissioning one bit, we've got local commissioning doing the other bit. When we're talking about local commissioning, as I've said, it's 135 organisations. And in some places that makes, because CCGs are not geographic organisations, they're population-based organisations, it makes a nonsense. So the bit that I'm most familiar with is obviously London, where we've got 30 CCGs in one city. Trying to wade through that is really difficult. So I have massive sympathy with the question, because it looks like we should just be able to do it. And I would agree that we should just be able to do it, but we need to be supported by our commissioning structure. And at the moment, we do things almost in spite of the commissioning structure. And that's something that I hope in the future we can start to influence and change through system-based commissioning, ICS-based commissioning, and outpatient transformation.
Yeah, and of course, Richard and I are on a steering group that's looking at outpatient transformation and restoration of eye care services, and there's a lot of discussion around new pathways to enable primary and secondary care to have a bit more joined up working, and the kind of work that's going on there is going on apace, isn't it, really, to try and look at how we can help see these patients in a community-based setting.
Absolutely. I think the issue has been recognised. That's a positive. How we now remedy the issue is what's in the mix at the moment.
Yeah, and I think there's no doubt that ophthalmology recognise the kind of skills that community-based optometrists have, and the way that they can manage patients in practice and help out in these kind of situations. Is there anything else that we maybe think we need to have in place to ensure primary and secondary care work closer together in future? Yeah, go for it, Rich.
I mean, to me, it goes back to what I've said before. It's communication, system interoperability. I mean, that needs to happen. It doesn't mean to say that everyone has to use the same system in the same way, but the systems need to be able to talk to one another. So I think that needs to happen, and that can come. Fundamentally, what I think we need is trust. So I think what's happened during the pandemic, and Colin, you've alluded to it, is that as services have had to evolve to deal with patient need, and also to ensure that patients who have needs but who may be vulnerable don't land up in hospital, we've had to build those trust networks, and we've had to build them really rapidly. And I think they have been built. I think once we get the communication right, once we get the trust right, if we can get the structures right, the acceleration that can be delivered is huge. The components are there. We just got to join them up. But it needs some fundamental thinking on the NHS side as to how they're going to go through these commissioning processes. And this is not an issue that's confined to us. I'm sure there's loads of people talking about diabetic services and cardiac services and MSK type services that are having exactly the same conversations. It's about this split commissioning that we've got to address.
Yeah, absolutely. And then somebody has just commented that they picked up on William's point that the commissioning of both the primary and secondary is integrated and coordinated, and it does seem to make sense from a structural point of view. Great. I mean, there was another question
Colin,
around. Yes, sure, Lesley. Go ahead.
Can I just come in on and pick up what Richard said about trust? Because I think that there are structural issues, but there are also cultural and issues as well. And I think we have started to make inroads in that culture. One thing I'm really interested in is whether you can actually build trust between professionals that need to work together and handoffs between one and the other through trying to look at standards that might be coherence of standards across the different professions, and also interprofessional learning, so that we have ophthalmologist training alongside optometrists in certain circumstances. So I think there's something about the education and exposure of the professions to one another in their kind of formative years, as well as when you're actually in the workplace as well.
Yeah, absolutely. And I think we maybe touch on it later when it comes to maybe higher qualifications and how these can be utilized to help deal with maybe patient backlogs and seeing patients in the community as well. And then we did have a question around glaucoma patients specifically, and again, it was whether they could be monitored and seen safely in the community. And I think there is as I've said, a desire to keep these sorts of patients out of secondary care and to be seen by appropriately trained, appropriately qualified optometrists in the community. And maybe Julie, with the IP side of things in Scotland, that's probably something that's worked quite well for you and in Northern Ireland and in Wales as well.
Yeah, I think in Scotland, certainly I can understand Richard's point with England. Although Scotland as a whole, there's different health boards within that, and within the different health boards there can also be different levels of engagement with primary care and secondary care as well. So I mean, obviously I'm based up in Grampian. You know, we do have a shared care kind of glaucoma system in place already, with a couple of practices in the community seeing glaucoma patients alongside, like sharing data through the hospital. We're also away as part of a waiting list initiative to start seeing some glaucoma patients in the community, but likewise sharing the data with the hospital so that ultimately they'll be receiving the data and looking at it. There's also ocular hypertension's been discharged into the community in some kind of areas as well, you know, for stable and stable glaucomas as well. There have been some. So yeah, certainly I think it's everybody working within their competency, but there's a lot that optometrists can do. I mean, we're seeing patients with glaucoma and ocular hypertension, referring them to the hospital anyway. So I don't see why with stable kind of conditions we could be monitoring themselves, or likewise sharing it with the ophthalmology.
Okay, great, thanks. I mean, we've sort of alluded to independent prescribing, and it would be interesting just to get the views of the panel as to how useful you see independent prescribing optometrists going forward, and maybe how we could maybe facilitate the qualification of more IP optometrists. I don't know if anyone wants to take that one.
I'm happy to start, Colin. I mean, as I said in my introduction, we've just set off this past week the first of our expert advisory groups on IP, and I think we do see it as really important. We're getting lots of messages back about increased demand at the minute, and we know that there are some issues with our current provision as well, that it's not always easy to get the placement after a relevant placement after people have done the theoretical study. So I think a bit like our work on undergraduate education, we are looking at ways to try and develop an integrated programme for IP going forward. But I also think that there are some questions about whether we couldn't bring that forward. The requirement for 2 years is how necessary is that? Could we actually begin IP at a much earlier stage? So I think all the messages we're getting, and I'm sure that Julie, William, Lisa, will be able to say more, is that the demand is there and has grown almost exponentially with the pandemic.
Okay, yeah, I mean that's the feeling that I'm getting, that there is a demand for practitioners to upskill, and IP is just one of the routes that they're looking at, because I think they've looked at colleagues working maybe particularly in Scotland, Wales and Northern Ireland, and seen how they've been able to utilise their prescribing rights and have access to prescription pads as well. So yeah, William, thanks.
Yeah, I mean, certainly IP, it seems like a natural progression really for any optometrist that wants to go down that route. it's probably the next thing that we want to look at in Northern Ireland, is to really establish an IP scheme. A bit like Julie was saying, we have an OHT scheme which has worked extremely well in Northern Ireland, and all stable glaucomas are now monitored in the community. It's been backed by an ECHO programme where the optometrists have regular meetings with the ophthalmologists and discuss cases and learn, develop, and that's been really, really successful. So the IP, yep, seems like a natural progression. We probably, like most people, have a bit of a bottleneck in that you can go and do the theoretical training, but then you can't get the placements, and that's where the problem lies. Whenever we look to move this forward, everybody has to work together. So ophthalmology, optometry, we all need to work together in this to ensure that there's sufficient places for any optometrist that wants to move to become an IP, that they can do so. That has to just be a natural progression, and there has to be the number of places per annum in place for them to do that.
Yeah, I think it's a really great point, isn't it? Because I think, you know, it has been recognised as being a difficulty, but it highlighted even more so by the inability to get into eye clinics, hospital clinics at the minute to complete any placements. So yeah, it is difficult. And Lisa, from a Welsh perspective, how do you see IP and the work that they do within your region?
Yeah, very much on a similar vein, actually. Again, working with Welsh Government, the aim is within the 64 primary care clusters across Wales is to have an independent prescribing optometrist in each of these areas. So I think that shows the value and how strongly that it's felt. And if I just make you aware, perhaps in the area where I work in Cardiff and the Vale, 80% of eye casualty cases are seen and managed by primary care IP optometrists with prescription pads. So I think that sort of fills the answer there very well. Yeah,
it's a really great statistic, isn't it?
Yeah.
It does bring home the point. And Julie, I don't know if you've anything to add on what you've already said around IP in Scotland.
With IP, I mean, we're lucky we obviously get funded kind of places in Scotland for IP training, and then likewise there's actually quite a lot of accessibility for hospital pre-COVID, you know, in a hospital setting. It was well supported, which is good, with teach and treat clinics across Scotland. The only other thing we have in certain areas, which is non-IPs are able to prescribe certain medication. So certainly in Grampian and in Lanarkshire as well, they've got kind of enhanced schemes where we can treat certain conditions like uveitis, marginal keratitis, herpes simplex keratitis. So we would see the patient and then work alongside a GP practice. So we would contact the GP and they would prescribe on our behalf, which could mean that the patient doesn't have to go to the doctor to get a prescription, and likewise they don't have to go to the hospital to get a prescription either. And it could be any optom that's registered with these enhanced schemes that can do that as well.
Sounds like a really streamlined process, and you've actually preempted one of the questions we had sent in as well. So thank you for that, Julie. Richard, from a LOXU perspective, I don't know if there's anything you would want to add around that.
Nothing particular, I don't think. I mean, I agree with all of my colleagues about IP, and certainly medium term, long term. It's obvious there is a role for IP. However, in the very short term, IP is not a silver bullet that's going to solve our problem today, because there's not a critical mass of people who are IP qualified. And as we've already heard, actually getting the clinical placements is, for me, getting the clinical placements is the biggest challenge in this. It's getting people through to that point, and how do you get people into the placements? So I think from a LOXU point of view, absolutely the value of IP is completely unquestioned. But I think it also needs to be, IP needs to be contextualized. And I think that if we are delivering services, if we're delivering different types of pathways, we need to look at everybody involved in those pathways. So that's all members of the primary care team. So optometrists, DOs, assistants, everybody who has a face-to-face relationship with the patient. We can maximize every element of their roles, whether they're core competency or extended qualifications. IP becomes a progression from that point onwards. And I think whilst I'm incredibly supportive of it, there is a cautionary tale here. In a previous life, as people probably know, I was a commissioning director. I used to be involved in commissioning services around diabetes, and there was a really big drive to getting GPs qualified to do insulin initiation in practice. And a lot of GPs qualified to do insulin initiation in practice. There wasn't the volume of work. And I think we just need to be mindful of that. It's not ever to say that somebody should not go and get IP qualifications, because they should. It's a natural progression in terms of their role. But I do think that we need to be careful about how the services then evolve around that.
Great, thanks. I don't know if, can you all still hear me? Because I seem to have lost my my camera.
I can hear you, but I can't see you.
Yeah,
same here. Same here.
Same here.
So it's just trying to connect it again. We'll carry on. If you can hear me, that's fine. I'm not quite sure what's happened, but I suppose it's really interesting to get that perspective, Richard. And yes, I can hear what you're saying. I suppose if we move on to the next question we have, it's maybe looking at those the changes, the permanent changes coming in that maybe might be to the detriment of patient care. I wonder if anyone wants to take that. I can't see if oh, I'm back again. I can see you all. I don't know what happened then. That was fantastic. Yeah, so that I suppose they're saying not change is good, but not all change is good. Is there anything that we need to just be mindful of that could impact on patient care in a negative way going forward? I don't know if anyone wants to pick that one up. Well, Richard, thanks.
I might have to start. I would hope that actually none of the changes that carry forward are to the detriment of patient care, because if they were, we wouldn't be carrying them forward. However, I think there are some cautions. So I think one of the positive benefits of what we've gone through in the last 6 months has been the use of remote consultation and certainly remote decision making. And I kind of think it's a bit like a pendulum. It's very easy to go from one position where you've not used it at all to the other end of the spectrum where it gets used as a default. And I think we need to understand that different patients in different places and of different demographics maybe need a different approach. And I think I think there's a risk that if we try and put everybody into a kind of one size fits all type service, it's not to the detriment of patient safety, but it might be to the detriment of the patient experience. And I think if we lose the trust between the clinician and the patient, then that might be difficult to get back. So that's one area that I wouldn't say I'm concerned about, but I think it's important that we monitor it.
Yeah, I think it's a really interesting point. I think we've been saying, oh, we must rush to embrace new technology and new ways of communicating. But I suppose one of the things we do need to be mindful of is that we do have a certain percentage of our patients are elderly and may not have access to this technology, and as such may get left behind. I don't know if there's any other comments that. Oh yes, William, thanks.
Hi, Colin. It follows on just perfectly from Richard. Video consultation during the darkest hours was absolutely fantastic. To be able to at least put people's minds at rest was superb. It can't ever replace face-to-face. And again, you don't want the pendulum to swing too far that direction, so it can't replace face-to-face. And the one fear that I would have is that if you want to put a technology in place that is perfect for a disruptor to come in and take over, it's video consultation. So once it becomes widespread, I just think it's perfect for somebody outside of the industry to take it on, take it to a low-cost economy and run it from there. And then suddenly you start ticking on. So you just have to be careful how far down that route we go. It's a tool, it's great, it can't replace face-to-face.
Okay, thanks. Yeah, I think, you know, we're realizing that having maybe an initial consultation and deciding if a face-to-face is appropriate, so that's maybe a way forward. But yeah, interesting. And I suppose the other thing that we've all had to adapt to working is with PPE. Is that something that you foresee that will have to work this way going forward? I wonder how long it'll be with us. I don't know if anyone's got any views or thoughts on that. It's maybe the unknown, isn't it? You know, if we're on maybe on a second wave coming in, who knows how long we'll have to use it.
I'll come in again, Colin, if that's okay. I think the simple answer is yes. We've now established PPE, and I think, you know, in the years to come, PPE will become normal at times. Hopefully there'll be times when we can step back from it, but I think it will be a thing that comes and goes. OE and I have sort of an intimate knowledge of PPE. The Health and Social Care Board supplied PPE for all practitioners in Northern Ireland, but the stumbling block was the delivery of it. So Optometry Northern Ireland kindly volunteered and took on the role of delivery man. And Friday saw us deliver the last box, which came to just under 1 million pieces of PPE delivered across Northern Ireland. And it was great to have the last box signed for. So PPE is in place. It's really important. As I said, I think it'll flex up and down slightly, but yeah, it's there for the long term, I think.
Yeah. Hi, Lisa. Yes, if you want to come in.
Again, just support what everybody said. I think that PPE really now is becoming the new norm. I think what we've also seen during this period is perhaps a little bit more of an emphasis on the focus on the clinical side of optometry, and I think that supports that too. With regards to the question that you said about things that we'd adopted from concerns during the COVID period, and the only other thing I'd like to add, and something that we're aware of in Wales, is waiting lists for patients. And, you know, in some specialities, we've got sort of 4 years waiting list for patients to be seen for the diabetic eye screening service. There's now a 4-year waiting list, and obviously that's a concern there, the diabetic screening service.
Yeah, I think we're maybe still at the stage where we don't know if we've got maybe a large amount of patients who are going to be coming in to see us that have got maybe avoidable sight problems that that have been put off during the pandemic. So I suppose there are those kind of issues that we need to think about and bear in mind as well. I think practices are maybe working on a slightly reduced footfall at the minute, and this is, again, William alluded to it, that the next 6 months I think are going to be quite crucial, and we have talked a little bit about support packages, but the GOS payments have been really welcomed by a lot of practices. I don't know if I'm sure we'd all love to see that support continue. But again, Richard, I think you alluded to it earlier that there'd been an announcement earlier that maybe those negotiations are still ongoing as far as England are concerned.
Yeah, they are. So we've, I mean, as people have seen the announcement, that's great. If you haven't seen the announcement, I kind of urge you all to go to relevant representative bodies, or you can come to the LOXU website because the announcement is on there. And what it's saying is that the discussions are still ongoing. The specific question that was raised was around support for September, and those discussions are still ongoing, even though we're in October, and looking forward to support particularly around those practices that are very much GOS dependent. That's ongoing. It's been, I don't think it's any secret, it's been a fairly torturous experience, but we are continuing them through OFNC and OFNC colleagues, and our aim is to continue to be able to pursue those to a successful end. at some point someone will write a book about it. There's been so many changes in terms of NHS England as well, in terms of how personnel and how things have moved. So it is ongoing, and the statement effectively says that.
Just kind of watch this space then going forward. And William, you talked about the support packages that were available in Northern Ireland.
Yeah, again, we've had tremendous support from the department and the Health and Social Care Board. In April, we put in an emergency package that saw us through to June, and then in June we put through in a package that sees us through to next April. So we have financial support in place right through until next April. And today the Minister of Health made an announcement that supports that right through until April. So that's superb. When it was put in place, and I know, I'm really sorry, I'm conscious of the guy who said earlier England is sort of behind Northern Ireland, Scotland and Wales, and I'm sort of just adding to his probably anger sitting at home at the moment. We've been very lucky, and again, from what Richard says, we have one or two people to speak to, and they have one or two people to speak to on our side. That makes it so much easier, and the trust that has been built up, again, that makes it so much easier. When we put it in place, I thought, brilliant, we have this in place until next April. I'm now looking at it thinking that's 6 months away, and 6 months will go in very, very, very quickly. And I think in the very near future, we need to start talking beyond next April. This isn't additional money, this is money that's in the budget, but it needs to be used in the proper way. And I think we are in a great position in that we have that support through to next April, but I think we need to start looking beyond that in the near future, and similarly in Scotland, Wales and England.
Yeah, absolutely. I mean, it's just amazing how quickly the last 6 months actually has gone when you reflect back on it, and the changes that have happened, and kind of who knows how quickly the next 6 are going to go. And you're right. Let's preempt. Lisa, in Wales, what are the sort of current plans and situations?
Yeah, in Wales, you heard me say earlier on this evening, is that the profession in Wales from March to August, we received a very generous taking from Welsh Government, and the way that was done was that 3 years of claims were taken into account across all 3 service areas, so including GOS, the low vision service and EHU. After that, the profession sort of reverted back to sort of a sense of normality, and as you may well be aware, in Wales now there's a significant amount of lockdown, local lockdown, but interestingly the data, and indeed the majority of the profession, are not seeing a significant reduction in footfall. So we've got quite a sophisticated data capture process going on, and what this has been showing is that patients are keen to attend practices and are keen to spend. In most of South East Wales, which has the highest concentration of optometric practices, although they're in their second wave, as I said, the data capture has started, and again, just to reinforce that, we're not seeing a significant reduction to justify further average payments. So at the moment, we're just looking at, as I say, the figures that are coming in, and we'll respond accordingly. But currently, the profession seems to be quite content with the numbers of patients that are presenting in practice and the income that's being generated.
Okay, that's really encouraging, isn't it? And what's the Scottish perspective on that, Julie?
Yeah, certainly in Scotland, we've had really excellent kind of relationships with the Scottish Government, and a lot of support through kind of average GOS, and also supplying PPE to practices across Scotland. It has changed slightly recently, but there's just ongoing talks with the Scottish Government. I mean, they're very aware that we are taking longer to see patients. There's PPE and infection control measures in place. So although there's the demand for appointments, it's the amount of appointments we're able to see during a day as well, and the fact that that will change kind of as winter comes, and they're talking about other spikes as well. So it's promising that going forward there will be some support, but we don't know what the support will look like. But that is something that is kind of ongoing discussions with them at the moment. There's also with the waiting list initiative, with these patients that potentially been seen from secondary care into primary care, and what's encouraging is in this situation, the money is following the patient. You know, that's something that was said before with kind of patient-centred care. It's all great seeing it in the community, but it's to make sure that the funding is in place for that as well, so that we could support from primary care setting.
Okay, great. Thanks, thanks, Julie. We've had a question come in around if we're going to be using PPE and then having to clean rooms down, and there is a demand for patients. Do we need to be mindful of the kind of appointment times that we devote to patients? I don't know if that's anyone wants to. Yep, Julie.
I'm happy to answer that. I think every practice will be different. You know, everyone's got a different setup, different teams in place as well. So certainly some practices, their appointment times would be longer. Other people will maybe have adapted different ways of working to ensure. So it would be very variable. You know, you couldn't put a specific time on an appointment, I don't think, just based on that.
Yeah, and I suppose if we think about making sure that you're safe, your staff are safe, and your patients safe, there's something around risk assessments as well, isn't there, to ensure that you have got that safe environment, that patients are confident that it's a safe environment as well. So we did have a question around domiciliary eye care, because of course we've got a proportion of patients that can't get out, and that there has been talk about difficulties within care homes throughout the pandemic as well. So I don't know if anyone's got any experience on the impact that the pandemic has had on domiciliaries. Yeah, William, thanks.
Hi, Colin. I probably have to declare a conflict of interest or whatever at this point. I would be the largest provider of domiciliary care in Northern Ireland, and we established that 20 years ago. We thought we knew everything there was to know about domiciliary care. We thought we knew how to provide it, and in the last 3 weeks we haven't had a clue. The impact has been absolutely huge. We were very conscious during absolute lockdown of all of the residents of the care homes in particular who couldn't access any care. It's so important to them in terms of their mental health, their mobility, even nutrition. All things are impacted by their visual status. So we're very conscious of that for the 5 or 6 months that we couldn't actually go into a home. But it was also the right decision not to go in. They had to be protected, and that had to come first. So we were fully supportive of what was put in place at the time. In Northern Ireland, we've only been allowed back into care homes in the last 2 or 3 weeks, and it is proven incredibly difficult for a number of reasons. We go through a number of steps in order to organise the eye examination. It includes possibly speaking to the resident if they're able to do that, certainly speaking to family, next of kin, representatives, care homes. We do all that. We seek approval from the Health and Social Care Board. We go to the home, and quite often we have the door closed in our face. We don't get through into the home. And again, it's for all valid reasons. When the home requested the eye test, they were in one position. 4 days later, when we attend, the home's in a different position. So there's a number of things that happen on a regular basis, but days completely fall apart. So days that you think, I have an optometrist, I have a day's work, we know what we're doing, we're traveling 140 miles to see 5 patients, it completely falls apart. So it's very, very difficult. And actually the same thing happens in people's own homes as well. The person asks for a test, it's all organised. And then maybe there's an announcement on the television by one of our politicians, and they lose confidence. And between booking the test and going, again, they decide not to have it, or a family member says something. So it's very, very difficult to book eye examinations and provide eye examinations. But we will get there. And there is such a need, and such a obviously pent up need from 5 or 6 months of no service. We are seeing people who desperately need to be seen. and we know the benefit that domiciliary eye care can provide. It's difficult, PPE is difficult, the reduced capacity is difficult, but such is life. So it's not an easy thing to do at the moment, but it's very important, and safeguarding the residents and the people in their own homes takes precedent over everything.
Yeah, well, thanks, William. It sounds incredibly challenging, but thank you for sharing that. It's really interesting to get that perspective. Now, I'm just really conscious of time, so I think we'll make the last question the last one, the next question the last one, and get my words right. So really, we're at a stage where maybe we might have slightly more restrictive measures coming into place, but I just want to ask the panel if they feel that practitioners are maybe better prepared to adapt their practices and continue to provide eye care safely if things do change. So I don't know who would like to answer that one first.
I'm happy to go, Colin.
Thanks,
I think
Lesley.
so. Yeah, I mean, I do think so. We're just in a much better place than we were at the beginning of March. I mean, people just didn't understand, the impact of the virus or how to control. So, and we didn't have the equipment, we didn't have the the PPE, etc. So I think that the situation now is vastly different, and I can't imagine we would get back to a position of kind of complete lockdown as we had before for this sector. Maybe for some other retail sectors, but not for this sector now that we've got those arrangements in place. And I think it is from our point of view just about enabling our registrants, again I keep coming back to it, just to be able to use their professional judgment and to support them in using their professional judgment. And yes, things won't always go perfectly well because there will be new things around the corner that we've not anticipated, but I think that the degree of change is settling a little bit.
Okay, thanks. And Richard, have you got a thought on that?
Actually, no. I would have said what Lesley said. Actually, that I think we're in a much better place going into this now, because the kit is largely speaking in place. We have a better understanding of how to manage the services in a much more COVID secure way. But I also think actually the general population have a better understanding of how to experience and approach practices in a way. I think that'll make a difference. So I think we're in a better place. The only thing I want to say is that is not to downplay that. I think the difference between the first time and this time is, I agree, I don't think we'll go into a national lockdown position, but I think we may find ourselves in very localized lockdowns at some point, and it's very easy for us to sit here and say, yeah, I think we're going to be better prepared, I think it's going to be fine, until you are the practice that's in an area that is completely locked down, and someone somewhere is going to experience that. So we have to make sure that we have the mechanisms in place to be flexible enough that if the majority of the country, England as far as I'm concerned, if the majority of England is operating kind of normally, but one area isn't, that area that isn't can still be supported. So I think we're in a better place, but who knows? We don't quite know what a second wave, if a second wave, I think we're probably in a second wave, but if it really hits, we don't quite know yet what that's going to look like.
And I suppose, Lisa, maybe in South Wales, you're experiencing that a little bit more firsthand. What's your reading of the situation at the minute?
Yeah, I think full credit to the profession and actually all the stakeholders. I think what's happened in the last 6 months, we've adopted so much good practice. We've, as we said, it's certainly been a catalyst for change. We've learned and taken on so many new practices and procedures. We've got our technology, the PPE, the systems, the remote working, all the information that's been shared, and the good bits have certainly risen to the top. And again, the profession has sort of prioritised, patient care, dealing with patients as safely as it's allowed. And I'd like to think, and I'm confident that this sort of working will continue.
Great, thanks. And Julie, I think in certain areas of Scotland, we're in a similar situation around, particularly Glasgow. There's more local restrictions, and are practices coping well? Are they geared up for it, do you think?
Yeah, I think so. I think, like everyone said before, we're in a different place now with infection control and PPE as well. In the local lockdown areas, it wasn't affecting optical practices as such. There was maybe a heightened level of anxiety to come in for an eye exam, but the practices themselves were still in operation. We also had the added benefit of furlough still being in place as well, the flexible furlough scheme. So I think going forward, that is also something to be mindful of if we're going into kind of local lockdowns. It's certainly something to kind of be thinking about. But no, I think as a profession generally, it's we have achieved so much, and I think we've learned a lot as well from it. So I think although there is a lot of kind of worry out there if it happens again, I think we're better prepared than we were, but we don't have all the answers, and we'll still probably learn a lot if we do.
Thanks, Julie. And finally, William, if I could come to you just for your final thoughts on that.
Again, probably the same as everybody else. In March, I went to a meeting with the Chief Medical Officer and they discussed PPE. I didn't know what PPE stood for. I was sitting there thinking, what are those initials? Now it's second nature. It's what we do. So yes, we're in a much better position now than we were back then. We just have to watch for complacency, that we don't become too comfortable with it, and remember exactly how to use it, how to put it on, how to take it off, how to dispose of it. It's keeping that vigilance high and keeping all staff on board with all of the little steps that add up to a safe practice.
That's a really great point, William, and I think probably a nice one to finish on as well. So I think sadly that's all the time we've got for questions this evening. So I'd just like to thank everyone that sent in questions, but most of all the great panel tonight, and thank you for your open and honest answers to the questions that you've been asked. And I'll probably invite you all to switch your webcams off, but it's been great to see you all.